Hello guys, I hope you're doing great. This is Dr. T from Clinical Medicine with Dr. T. So guys, I feel like we are leaving our ortho friends behind, those who are rotating in orthopedics, because we have only done 2 teachings in orthopedics. So I want us to do something in orthopedics. So I want us to do upper limb fractures. So today on this episode, we're gonna cover Monteggia. Okay guys, I've got advice. Before I start this video, I just want to give you small advice. This advice goes to the students and the interns. Guys, I want to urge you to try and avoid this trap of specializing before you actually specialize. Let me say it again. Try and avoid this trap of specializing before you actually specialize. And what do I mean by that? There are students and interns who like certain departments, even from school, and because of that, they decide I'm going to specialize in that department, and then the other departments, they don't take them serious. When you do that, you are disadvantaging yourself, because you're supposed to be learning as an intern and as a student so that you can be a GP. We are being trained to be GPs, not specialists, but GPs. So if you, because you love internal medicine or you love ortho, you take those serious, and then when you go to peds, you're just doing it, you're just there, you're not active, you're not proactive, you're not answering questions, you're not studying, you're just there, you are disadvantaging yourself. Yes, you will pass, but when they put a patient in front of you from those departments that you never took serious, you will struggle. And also, the issue of getting reg posts now is becoming harder and harder. So while you're waiting for a reg post, they take you to maternity, the same maternity that you were dodging and doing all sorts of things, you are going to have a horrible time there. You are gonna miss things, because you would lack the basics of being in that department, or they just take you to surgery and you know that you love peds. So avoid that, guys. I hear that a lot, and I feel it depresses me, because you will never know where life is gonna put you. And also, you might think that you love surgery now. Then in the next few years, you're like, no, this is not for me. And then you change. But you will be changing to a department that you never took serious, and you will be lacking the basics of that department. So avoid that, guys, please. And also, let's talk about one other advice now. When it comes to orthopedics has got a lot of neurology in it. And it doesn't make sense for me, it doesn't make sense that you go into orthopedics but you don't love neurology, because there's a lot of neurology in orthopedics. And that's the difficult part. Identifying a fracture and describing a fracture is all nice, it's beautiful, but what about the nerve that is under that fracture? What about the artery that is under that fracture? Did you assess it? Do you know how to assess a neurological status? For instance, if you've got a fracture in the humerus, and it's at a location where you suspect that it might have snapped the radial nerve, do you know how to assess radial nerve, whether it's intact or not? Those are the things. Because everyone can see a fracture, can identify a fracture on an X-ray, but what differentiates us from the other people is that when a fracture is in that location, we know that the likely complications in terms of the neurovascular is this and that and that and that and that and that. That's what makes us different. And another thing is, when you approach orthopedics, when you do orthopedics, a fracture that has got a name is very important. It makes you look good as a student, but it's very, very important. A fracture with a name, it's a special fracture, and they like to put those fractures because, like for instance, a Monteggia is a special fracture, and I will tell you why Monteggia is special. And also, a fracture that has got a name is important. And then you get isolated fractures that are not special, it's just a fracture. Describing them is also important. But A fracture with a name and the classifications are very important. I know there are doctors who say that we are not specialists, so knowing the classification is not important, but I beg to differ because, for instance, if you've got a supracondylar fracture, I want to know, is it a Gatland 1, 2, or 3? Because I know a Gatland 1, I can keep that patient as a GP and put a POP and I send the patient home. But a Gatland 3, that's a complicated fracture. It's a very unstable fracture. I would want to get an opinion of the orthopod. But now, if you don't know if it's a Gatland 1 or a 2 or a 3 because you never took classification serious, you'll just know that it's a supracondylar fracture. So you'll either send that patient home or send everything to orthopedics. It's like Weber classifications. If you don't know that Weber C has got syndesmosis injury in it, then you will keep a fracture that is not supposed to be kept by you as a GP. So personally, I love the names. I love classifications. They make life so simple. So okay, guys, let's jump into this one. So Monteggia, what is a Monteggia? Monteggia is the name of a person. So this guy realized that there are fractures that involve, this is our olecranon, this is our ulna, so this is our humerus, so this is our ulna, right? Our olecranon. So Monteggia, this is our head of the this is not drawn according to scale, guys, ne? This is the head of the radius. So Monteggia described fractures of the proximal third of the ulna that goes with a dislocation. That's a Monteggia. So Monteggia is a special fracture because it goes with a dislocation of the radial head. That's what makes it special. Otherwise, if it was just an isolated ulnar fracture, it would be just an isolated ulnar fracture, nothing special about it. But the fact that there's a dislocation, it becomes special. That's why it's called a Monteggia. And also, if you see an X-ray and there's a fracture in the proximal third, and then there's a dislocation, and then they ask you in an exam, or even not, forget about exams, because we are not taught to pass exams, but to be safe doctors. If you see a patient in X-ray, you focus on the fracture only, you will miss the dislocation, and you will manage the fracture only and miss the dislocation. And even on your notes, you will say it's an isolated fracture of the proximal ulna and not say anything about the dislocation. The right name for this kind of a thing, it's Monteggia. So if you call someone and say, Doc, I've got a Monteggia, he knows that you are saying to him, you've got an ulnar fracture, a proximal ulnar fracture, specific. Number two, you are saying there's a dislocation of the radial artery, the head of the radial artery. This is the head of the radial artery. So that's what you are saying when you say Monteggia. Let me write it. So it's a proximal ulnar third fracture plus radial head dislocation. That's a Monteggia. And this is different from a nightstick fracture, or it's different because nightstick fracture, by definition, it's a fracture of, it's usually the middle third of the ulna, but there's no dislocation. So it's one of your defense fractures. You know, anatomically, if you stand like this, your radius is on the lateral and then your ulna is on the medial. So when someone is hitting you, you do this, you pronate, because you're defending your face and your head. So you pronate. As you pronate, they hit you here. So it's called a nightstick fracture. So they hit you there. So it's usually an isolated mid-third or mid-shaft ulnar fracture. There is no dislocation. But the minute you get a dislocation there, it's no longer a nightstick fracture. It's a Monteggia. Okay. So that's a Monteggia. What what I want you to keep here is that it's an ulnar fracture. And not just an ulnar fracture, the proximal third plus radial head dislocation. You are done describing a Monteggia. And this fracture can happen in anyone. Peds, elderly people. As they say, it's more common in, I've seen it in old people. So, yeah. And also, the rule of two becomes, the rule of two in fractures. It becomes very important. 2 x-rays, 2 views, 2 joints. The 2 joints becomes very important. If you request an ulnar radius fracture or a forearm, if you request an ulnar radius x-ray or a forearm x-ray, it's a must that you must be able to view both of those joints. That's why I get so frustrated when I get an x-ray that only shows one of the joints, because you cannot commit if you cannot see both of those joints. You cannot say if it's a Monteggia or it's not a Monteggia. You cannot commit and say it's an isolated ulnar or a radial fracture, because you don't see the joints. So you need to see both joints so you can confidently and say it's an isolated ulnar fracture. When you say isolated, you mean it doesn't have a dislocation and it doesn't have fracture, 2 fractures in different locations. So the two joints role becomes very important in diagnosis of this. All x-rays should have 2 joints exposed. Yes. Okay. So let's talk now about the classification of these fractures. Okay, another thing that becomes special about this fracture is the fact that, remember the posterior cord from the brachial plexus, the posterior cord becomes as it goes down, it becomes the radial nerve and gets into the groove of the radial groove. As it comes anterior in the cubital fossa, it splits into 2. It becomes the superficial radial nerve branch, and then the deep. And the deep, it goes a short distance, and as it enters through the interosseous membrane, it becomes the posterior interosseous nerve. And it's very special. So, which means that with this kind of patients with a dislocation in the fracture, we need to examine for the posterior interosseous nerve. This is the nerve that is at risk of snapping during these injuries. Because you have a fracture here, got a fracture there. So you can injure it by the dislocation or by the fragments of the fracture. So we're going to talk about that. So let's talk about the classification of the Monteggia. How are they classified? So there's what they call the Bado classification. The Bado classification. It's a simple classification, guys. It's 1, it's 2, it's 3, it's 4. With a 1, you've got the apex of the fracture. The apex of the fracture, the apex of the fracture is anterior, and the dislocation of the radial head is also anterior. So it's like that. It's pointing anterior. So the 2 fragments are like this, but they are pointing anterior. And then dislocation is also anterior. That's 1. So it's posterior. I said posterior. No, I said anterior. Sorry, guys. This is anterior. So if the 2 fragments are pointing towards this direction, like here, this is anterior, and also the dislocation is pointing towards that direction, which is this. That's a 1. So this is anterior. The anterior, so the apex, they call it the apex, is anterior, and the dislocation is also anterior. The radial head dislocation is anterior. When these are pointing downwards, that's a posterior, it's at the back. So it's like this. And then this guy is also pointing like that. Is also pointing down like that as well. The head is pointing down like that. So that's a 2. So just go and check the pictures of these. But this one is like this, that one is like at the back. And then when you've got a lateral displacement of the radial head, that's a 3. Lateral radial head dislocation, that's a 3. Now this one is more difficult in the sense that you've got 2 fractures there. Your ulnar fractures in 2 places. So sorry, you've got an ulnar fracture and a radial fracture as well. So this one is more problematic. So that's called the Bado classification of the Monteggia fractures. Again, Bado 1, the apex and the dislocation of the radial head is pointed anterior. Bado 2, the apex and the dislocation of the radial head, the apex of the fracture and the radial head pointed posterior. 3, the lateral dislocation of the radial head. There you've got 2 fractures. The ulna is fractured and the radius is also fractured. We are done with the classification. Very easy, simple.